Hi everyone. Today we will be discussing about the Lefort osteotomy, its indications, procedure and complications. Lefort fracture is the fracture of the dentoalveolar segment of the maxilla. But in Lefort osteotomy, we intentionally fracture the dentoalveolar segment to resolve the function and aesthetic problems. This is a very dependable procedure, predictable procedure, and it has very low complication rates. So the basis of Lefort osteotomy is the revascularization study of Bell, which indicates that the maxilla can be mobilized and repositioned and the healing continues as long as the mobilized maxilla is positioned on a soft tissue base, which means that when we perform the osteotomy procedure, if the soft tissue pedicle is present on the periosteum of the bone, we can place the maxilla at its previous position. Now, why this is so? This is so because there are rich anastomosing collateral vasculatures present in the facial area, which results in excellent repair and healing of the maxilla. That's why while performing the osteotomy procedure, we should always try to preserve the soft tissue pedicle. So what are the indications of Lefort osteotomy? That is, when do we perform such kind of procedure? When the surgical repositioning of the maxilla is needed, whether it may be in the superior direction, inferior direction, anterior direction or posterior direction. When we segment the maxilla to widen, narrow or to improve the symmetry of the face or to level the maxilla so as to bring the maxilla and mandible in a occlusal plane in post-traumatic patients, in cleft lip and cleft palate patients, in nasomaxillary hypoplasia patients, and in patients with mandibular prognathism, that is, the mandible is in forward direction and the maxilla is in backward direction, whether it may be since birth or due to any trauma. So what type of incision is made? A horizontal incision is made above the apices of the teeth, usually the canine and the premolar in the buccal sulcus area throughout the periosteum. It extends from the zygomatic buttress to the midline and again to the opposite side of the zygomatic buttress region. So in the region of the frenum, the incision is curved into a small V so that it can accommodate the labial frenum as well. So we can see here that the incision is starting from the highest point of the buccal sulcus in above the canine or the premolar from the zygomaxillary buttress. It is again moving in the direction of the labial frenum. Here at the labial frenum, the incision is made in a V shape so that it can accommodate the labial frenum as well. And again it extends through the another side of the maxilla. So let's go through the procedure. The bone cut is made 5 mm above the apices of the canine and molar teeth. The cut is started high in the aperture area and extended posteriorly, sloping downwards and backwards to the tuberosity area. So the cut is made 5 mm above the apices of the canine at the highest point in the buccal sulcus and extended posteriorly, sloping downwards and backwards in the tuberosity area. These are made with a burr or striker's saw. So in cases where the vertical heights of the maxilla need to be reduced, the bone which we have cut, it can be collected and preserved so that we can use it as a bone graft later. Once the lateral cuts are completed, an osteotomy is used along the lateral wall of pyriform aperture to separate the dentoalveolar part from rest of the maxilla. Here we can clearly appreciate that the incision is made 5 mm above the canine region. It is moving in a posterior, backward and downward direction towards the tuberosity area. This incision at the zygomatic buttress is made using the reciprocating saw. We can use the osteotome to separate the dentoalveolar part from the rest of the maxilla. After separating the lateral wall of the maxilla, we need to separate the nasal septum from the maxilla by using a notched nasal septal chisel, which is directed along the floor of the nose. So we can see here, this is the notched nasal septal chisel, which is directed along the floor of the nose. A finger is placed along the junction of the hard and soft palate afterwards to confirm the separation, that whether the maxilla has been separated or not. We need to confirm this by placing our finger at the junction of the hard and soft palate. After separating the nasal septum from the maxilla, the maxillary tuberosity is separated from the pterygoid plates using a curved teaser osteotome which is directed downwards and medially. So this is the teaser osteotome which is directed in a downwards and medial position, and then we separate the pterygoid plates from the maxillary tuberosity. So the lateral wall of the maxilla has been fractured before, and the nasal septum has been separated from the maxilla. We have seen it in the previous slide. Afterwards, with firm pressure applied over the anterior alveolus, the maxilla can be down fractured to complete separation. That is, we apply a firm pressure at the anterior alveolar area, and then we move maxilla in a downward direction to completely fracture it. After the osteotomy cuts are made, the maxilla can be mobilized and repositioned superiorly, inferiorly, anteriorly, and posteriorly. So once the dentoalveolar segment of the maxilla has been completely fractured, we can move the maxilla in a superior, inferior, anterior, or posterior direction. And then the maxilla can be positioned using a splint in the plant position, and we can fix the maxilla using the bone plates. So here we can see that the maxilla has been placed at the desired position using the splint, and here we can fix the maxilla using the bone plates. Maxilla is also positioned to correct occlusion, that is, we maintain the maxillary mandibular occlusion relationship, and then the wound is closed. Complications of the Lefort 1 osteotomy are injury to the Stensen's duct, infraorbital nerve traction injury, unanticipated fractures, injury to the maxillary artery and its branches, lacrimal duct injury, or vascular necrosis. There can also be complications like the velopharyngeal insufficiency, nasal septal deviation and buckling, flaring of alar base, arteriovenous fistula, maxillary sinusitis. So this was all about the Lefort 1 osteotomy. Thank you.